Our next speaker is Dr. Geoffrey Rubin from the University of Arizona, who's a pioneer in the use of CTA, but we brought him along anyway. And Jeff is going to talk about when and why I choose CTA over MRA.
Thank you, Paul. Good morning, everybody. It's really a pleasure to be here. If you want to blame someone, blame me. I actually did my first CT angiogram in 1991. I had just come back from the RSNA presenting a study that I did as a third-year resident using gadolinium for assessing different methods of pulmonary MRA angiography when I learned that we were going to be receiving one of the first spiral CT scanners in the United States. This was a single-row scanner. It had slip ring technology, capable only of a pitch of 1, but the technology fascinated me, and I loved the blood vessels. I went to one of the revered professors in the department, this was when I was at Stanford, and told him that I really wanted to see whether or not a rapid arterial or a rapid intravenous injection to catch the arterial phase of a breath-held scan through the renal arteries using the new spiral CT scanner would be something that he would support. And he told me, absolutely not, do not do it. It is not a good idea. And he spent the next 5 or 6 years saying that all of the images that we created with CTA were cartoons. It was an interesting decade, the 1990s. I will say that CT was brand new, a CT angiography at least, by the time 1992 went around, and I was presenting 8 abstracts at the RSNA on the topic. But MRA was clearly had the lead at that moment in time. And by the mid-90s, we had gotten to the point where we were having debates every year at the RSNA, and we filled huge auditoriums. And I was up against a variety of folks. Usually it was either Martin Prince, who I'm delighted to see, good friend here. These are all great friends. Tom Grist, Jörg Debatin, Neil Rofsky. We would team up here, and it often felt like I was sort of the lone voice for this new technology. And I will say that also within vascular surgery and cardiac surgery meetings where I would go to speak, people were very, very skeptical. But by the late 90s, when we had multi-row technology coming out and such, we were starting to feel really confident with what we were able to do with the technology. And MRA seemed to be just sort of moving along at a steady rate. And then, of course, today, CTA is the 800-pound gorilla, and MRA is largely an ivory tower application. And I think that the discussions that we've just heard are very cogent to this incredible evolution that we've heard of. I thought I would share some data from our institution, Banner Health. Banner Health operates 30 hospitals through 4 states in the Southwest, mostly Arizona, but also California, Colorado, and Wyoming. We perform 626,000 CT and MRI exams per year across our network. With respect to the distribution of CTA to MRA, it's almost 10 to 1. Here you can see the different applications. I took these data just from our electronic health record across our system. You can see that MRA really just kind of registers mostly in the head and neck area. I included cardiac applications here. And so even for cardiac applications, CTA and CT is used at least 4 times more frequently. And if you just look at our hospitals, our 2 hospitals within Banner, which are university hospitals affiliated with the University of Arizona, you can see that there is a greater use of MRA. It's about 5-fold increase, or I should say 5-fold more CTA than MRA, but that's about a doubling of the relative use of MRA. And that's mostly through cardiac MR exams and head and neck exams. So when we talk about CTA versus MRA, what are the rationale? Why do I see that CTA is the dominant tool? The first one is the principle of systemness. And systemness is something that has become increasingly prevalent throughout the United States as well as worldwide, as there has been an aggregation of hospitals, of healthcare provider networks into larger and larger systems where effectiveness is largely derived through consistency and being able to assure that patients are treated the same and with the same quality regardless of where they are. And so Banner Health is an example of this growing type of multi-hospital system with 30 hospitals, and as I mentioned, CTA use is 10 to 1 there. CT is also faster to acquire for the patient. It is more available, and as we just heard from the data in Scotland, that it is exclusively the modality in the ED. That's an example of its availability. High-quality images are easier to acquire. In general, a single acquisition is pre-protocoled and will be much more consistently deriving diagnostic and even high-quality images relative to some of the customization and dinking around that one has to do with the MR scanner. It's less expensive. And with one acquisition, we essentially have a simultaneous visualization of the vessel lumen, the vessel wall, the associated structures adjacent to them, the end organs. It's all done one scan. And in MR, as we know, oftentimes there are multiple pulse sequences, multiple planes, multiple strategies to try to derive a comprehensive exam. And once all of that information is acquired, then you have to sit down and look at it all and integrate it in order to make clinical decision making. It's also excellent at depicting exogenous structures, namely metallic structures, as we've seen a little bit, and as I will show you in a moment, as well as other types of devices and fixation hardware, which is particularly important in the practice of medicine. With respect to acute circumstances and being available immediately in the polytrauma patient, sometimes it's critically important to establish the integrity of the vascular system. Here you see a patient with a highly comminuted tibial plateau fracture and the CT angiogram establishing the patency of the popliteal artery despite diminished pulses that were felt at that time. Here is a woman who had a displaced mid-tibial and fibular fracture, angulated and displaced, no pedal pulses. The quick CTA showed transection of the perineal and posterior tibial arteries. I don't know if I have a light. Is this a pointer here, this little guy? No. Okay. So I'll just describe, and I apologize for those of you who aren't familiar with the anatomy, but the two little balls that you see about a third of the way down represent little pseudoaneurysms at the area of active extravasation. Here is a patient who is not an acute problem, but this kind of vascular mapping very critical in determining the clinical decision needed. And I want to emphasize that we do cardiovascular imaging to make clinical decisions. And ultimately, the tool that will be used has nothing to do with sort of the true beauty of the image, the desirability of the underlying technology. It has to do with providing information to be acted upon. And so, whoops, okay, I see. This has a laser pointer somewhere. The center button. Got it. Thank you so much. Let me see if I can go back. There we are. Okay. So, so in this particular instance, this is a patient with chronic tibial osteomyelitis and needs to have a graft placed in order to treat a resection of the bone. And so what was critical to be determined here was that we have patency of the posterior tibial artery across the ankle into the lateral tarsal artery with patency of the deep plantar arch and retrograde filling back up into the AT. This is the anterior tibial artery coming down here. So now the surgeons know that they can take this anterior tibial artery and use it to provide blood supply to the graft so that it will be survive here and they will not hinder blood supply to the foot. This is the clinical decision making that needs to be made. This is readily evident from this study. Oopsie. Okay. An application, and it was really interesting seeing the Medicare data, but it's important to recognize that Medicare data is in older people, and there are different diseases that people get as they age. And so here's an example of a 16-year-old patient. This was a high school volleyball player who was having pain in her ankles and her calves when she was running up and down the court. There was concern for popliteal entrapment syndrome, and I show you this case just to highlight how easy it is to do maneuvers such as this forced plantar flexion against a sheet in the CT scanner. Here we see nice depiction of the underlying muscles and to then scan it in the relaxed position. We go down and up with one scan. And what we see in this particular instance is that with provocation, there's a lack of flow in the popliteal artery. The flow returns in the relaxed state, and here you can see the reason why. The popliteal artery bilaterally is anomalously positioned medial to the medial head of the gastrocnemius muscle, which we can see here. Normally, the popliteal artery would be here. Very quick demonstration of popliteal entrapment syndrome. And here it is in the stress state and relaxed. So I want to highlight, across the body where this is so useful. This is a patient with an acute aortic syndrome. The patient has an aneurysm here in the descending thoracic aorta. There's extensive thrombus within it. I don't have controls to stop this video, so I'm going to ask you to concentrate on the unenhanced scan, and we're going to see a crescent of high attenuation material right here, right there. And that is the bleeding in the wall of the artery. We can directly visualize not just the lumen, but that breakdown of the aneurysm with active bleeding together with pain is a critical emergency of impending rupture. And this is a demonstration of the utility of CTA in the setting of acute aortic syndromes. Here we see a patient who has a stent graft in the abdominal aorta being used to treat a huge abdominal aortic aneurysm. It's about 11 centimeters in size. There is a small endoleak. This is contrast enhancement around this metallic device as we come down. And so the question is what is the cause of this endoleak? What is happening in this patient? I will show you some more detail in a moment, but 6 months after that scan, the patient presented with an acute abdomen because they had a rupture of their aneurysm. This is all blood now in the retroperitoneum. The heterogeneity within the aneurysm sac is all evidence of instability and a consequence secondary to this rupture point. And so what can we see with CTA, and what can we see with CTA to explain this? Here we are at the original scan, and there is a subtle disruption of the structure of the metal here in this stent. It's not just a matter of seeing the stent and seeing inside of it. It's understanding the structure of the metal to be able to appreciate what is going on. There is a break, a fracture of this metal stent along the greater curve down here. Incidentally, it's not surprising that it is the place of emergence of this stent graft from this very large aneurysm sac, a relatively fixed position to a point where the blood vessels are moving quite a bit with each cardiac pulsation, and so the stresses are going to land right at that point. Another demonstration here, the cartoon, if you will, showing this separation of the individual tines of the stent and the tear of the fabric that we can't see directly, but that we can infer due to the endoleak. So when we come back to the situation when the patient has an acute rupture and we look at this region, we can see that there's actually an even greater degree of disruption. And if it's a challenge to appreciate that as you see these standard transverse sections moving back and forth, the isotropic spatial resolution of CT now allows multiple visualizations across different planes, different methods. Hopefully you can appreciate there is complete transection now of this device. It is completely separated, as you can see here. This was all part of one device at this point. It has now separated wholly. This results in pressurization of the aneurysm sac, and then ultimately the rupture of the aneurysm and the acute bleeding and the surgical emergency that I just showed you. We see a breakdown of metallic components all the time. And here you can see a thoracic aortic stent graft with multiple fractures, pieces that are free-floating, pieces of separation here. And so this is really something that we see not uncommonly at all. When we're looking at the thoracic aorta and with the quality with which we are currently able now to see cardiac structures, it's not uncommon that we also see details in the heart and things that we might not expect, such as this dissection here of the proximal left main coronary artery. In this particular instance, this is a patient who had just had a stenting of the left main and left anterior descending coronary artery. It'll come back and show you in a moment. A very extensive stenting procedure, and it unfortunately resulted in the dissection. Looks like the video is going in the wrong direction, so I won't show you the stent. I'm sure you know what it looks like, but the dissection nevertheless detected. And so I just want to finish up by talking about the coronaries a minute, because this has been a tremendous growth area for CT and has huge implications for the growth of advanced cardiovascular imaging, because coronary artery disease is a major source of morbidity and mortality throughout the world and in the United States in particular. This is a study, this actually goes back to 2008 when this was acquired, but the images are nevertheless still quite good. Here you can see the left anterior descending coronary artery with a focal lesion here, and the beauty of the CT is not only do we see the luminal narrowing through here, but also the positive remodeling secondary to the accumulation of a mixed plaque at this site. And so CT has really shown its value for anatomic assessment of the coronary arteries, but also what has emerged is the use of machine learning in particular, and machine learning applications in CT are numerous, but I'll just highlight this one, which is the derivation of fractional flow reserve from the anatomic maps. And this is an example that essentially shows the physiologic impact of a narrowing here and the fractional flow reserve falling below a threshold of 0.8, which there's just so much data to unpack about this specific technology. We don't have time to do it here, but I can say that this is I think, a real game changer in the role of non-invasive imaging in preventing patients from going to the cath lab to have invasive angiography without an actionable lesion. And again, this comes down to clinical management and essentially eliminating what for many, many years has been a practice in cardiology of sending patients to the cath lab only to find that they may have disease, but it doesn't need to be treated there. And that is a big expense and a big morbidity to the patient. And using technology such as this is very, very powerful. Here is an example of another CTA showing a point relatively distal in the LAD with the diminution in the CT FFR, and here's the associated arteriogram, and these are the actual measurements from a pressure wire showing that drop-off and the one-to-one correspondence of this point to this point, which is really critical in planning where to treat the patient. The final case I want to show you highlights the power of CT in looking at the heart. It's really, as I mentioned, been a very important expanding area. Here you see a patient who came in with chest pain and fevers. We can see that there is a mitral valve prosthesis. There's an aortic valve prosthesis. Let's look at them more specifically. Firstly, with gating techniques, we have a very compelling ability to look at the actual performance and function of these valves. This view just showing the two valves simultaneously. Here's a view looking down the aortic valve directly, and we see this flow channel all around the outside of it. This is dehiscence of the attachment site of this valve with perivalvular flow secondary to a massive infection of the heart. This should not be here, and this is indication of a breakdown at the aortic root. We see that here as well, the detachment here of the valve, this metallic valve, no significant artifacts from it, but this important area of breakdown as seen here, as well as this pseudoaneurysm, which is coming out right from the left ventricular outflow tract immediately below the left main coronary artery. Important indication of the extent of infection, as well as this separation of the mitral annulus, which is now separated wholly from the its attachment site as well. So why do I choose CTA? Or when do I choose CTA? It's essentially always. And there are exceptions. And I do want to say that, as I mentioned at the beginning, I started out my life as an MR focused investigator and focused on pulmonary MRA. And I still have a warm place in my heart for MRA. So, I think that MR is really valuable in the heart for late gadolinium enhancement, T2 mapping, and characterizing infiltrative cardiac disease and characterizing the extent of myocardial damage secondary to ischemia and infarction. I think that it is useful for opportunistic cerebral vascular assessment when brain MR is being performed. So, if the patient needs to be studied need to look at their brain, MR is clearly preferable to CT for primary parenchymal abnormalities, most of them, and it's a great opportunity to look at the cerebrovascular system. In the setting of arterial wall inflammation, I think that MR, although PET, and hopefully we'll hear a little bit about that, I think is really very, very valuable here as well. Patients with particular radiation sensitivity, children that need to have repeated examinations and such, would be another area. And then finally, clinical curiosity and extra time on my hands. It's a great way to scratch your head and to discover very interesting things about very interesting patients. And with that, I want to once again thank you all very kindly for the opportunity to finally come to the MR Angio Club. Back in the 90s, I received several invitations from Tom Grist, and I wasn't able to come. And it's just really marvelous to be here in Los Angeles with all of you. And congratulations to the organizers and to the rise and stability of this great organization. My pleasure. Thank you.